Good afternoon. My name is Dave Arnold. I'm the Executive Director of NextGen Precision Health. It is my honor to welcome you all to this month's NextGen Discovery Series seminar, and also to welcome Dr. Tae Chung. Dr. Chung is an associate professor at Johns Hopkins. We've known each other actually for, I think, over a decade. We had a similar grant actually as we were going on our career development pathways, and both interested in aging, but Dr. Chung has really taken on a leadership role in the space of POTS, and he's developed a very excellent clinic at Johns Hopkins, helping patients that are impacted by POTS, which we'll learn about today. This is a disease in the space of neuromuscular that's very challenging, often to diagnose and also to manage. And Tay is really at the leading edge in this space. And also, the pandemic had a major influence on the prevalence of POTS, and so he's going to tell us how that interfaces with POTS as well. So without further delay, I'm going to hand off the stage to Dr. Tae Chung, and thank you for visiting.
Thank you very much. Well, thank you very much for inviting me to Missouri, Columbia. It's my first time. It's a beautiful place, very cute town too. And I really appreciate your invitation, and it's just amazing facility here. Like Dave said, yeah, I think we have a similar brain. I think Dave is slightly better than mine. And I became very interested in POTS and long COVID, and I've been running POTS clinic at Johns Hopkins. So today I'm going to talk about some more clinical topic, POTS and long COVID, as related to chronic fatigue syndrome. Just quick disclosure, I've been receiving consulting fee from Arginex and Regeneron because I've been running some clinical trials. Now, I think some of the audience here might have heard about POTS, which stands for postural orthostatic tachycardia syndrome. I think probably many of you or most of you might have heard about long COVID syndrome or post-COVID syndrome. There are a lot of different names for it for the same thing at this point. Technical name now, there's a thing called PASC, post-acute C-cause of COVID-19. But most people just call this long COVID, long haul COVID. And you also probably heard about these people after acute COVID infection, their virus is probably gone out of their body, but they have lingering severe fatigue, brain fogginess, and exercise intolerance. That's been really puzzling a lot of doctors and publics in general. Now, obviously, COVID is a new thing, like COVID pandemic started in 2020, but this is really not completely new phenomenon. I think doctors have been actually recognizing this problem even back in 19th century. This is a picture of Dr. Baird. He's a neurologist back in 19th century New York City. He coined the term neurasthenia. Literal translation is nerve exhaustion. And he described these patients who's coming into his clinic with the pain in their scalp, dryness, insomnia, a lot of fatigue and light sensitivity. And he said this is probably likely probably the most frequent, but interesting, but most neglected nerve disease of the modern times in 19th century. But unfortunately, I think it's probably still the truth. Even now, I mean, I think COVID pandemic has gotten a little better in terms of recognition. Still a lot of people out there, they don't know POTS, they dismiss it. Interestingly, Dr. Baird recognized that a lot of these patients coming to his clinic are young female patients from wealthy families in Fifth Avenue. So he called this disease of Fifth Avenue. And also recognized that a lot of these diseases are coming from industrialized countries, so-called first world country. So he called this Americanitis as well. Now, around the same time in 19th century, right after the Civil War, American Civil War, Dr. Da Costa recognized a lot of young soldiers coming back from the war developing this severe anxiety, palpitation, and orthostatic intolerance, meaning they have a hard time standing up or sitting up for a long time, and severe chronic fatigue. This is a picture of a fire soldier. And often these people develop these symptoms acutely right after some kind of infection, maybe fever or diarrhea. Now, in his original description, they look very much like modern day POTS, but there are a lot of men and women coming out of the war zone. So I guess there may be some overlap with some PTSD, not purely POTS there. But if you look at their 19th century manuscript, it looks very similar to what we call as POTS. Now, fast forward to 1993, Dr. Philip Lowe and Mayo Clinic coined the term POTS, postural orthostatic tachycardia syndrome. Now, these are essentially very similar patients with anxiety, palpitation, and standing intolerance, exercise intolerance. And he recognized that these people have dramatic increase in their heart rate on a tilt table test. Tilt table test is, like you can see in the picture, table literally just tilt up, usually to 70, 80 degree. And most people, if you're strapped down to the table that goes up, it doesn't really do much. But these population, not only their heart rate dramatically goes up, they reproduce all these typical symptoms of fatigue, headache, and brain fogginess, and a lot of GI symptoms there. Now, also at the same time, by definition of POTS, it shouldn't be coming from heart condition. You shouldn't have any heart condition, arrhythmia, or heart failure that's explained these symptoms. So that's kind of suggesting it may be some kind of neurological blood flow regulation problem. However, right at this point, before I move on, I want to actually clarify some terminology here. When I say POTS, there's an S there, which means syndrome. And for those who are not really clear about this, syndrome is a little bit different from disease. I mean, there's a really gray area in terms of definition, but when doctors label something as a syndrome, that means we don't know really much about what's going on. It's a little broadly defined, but there's a common signs and symptoms. So basically, it's a thing. We see these people, it's a real stuff, but we cannot quite call this actually a disease yet. This is when you call a syndrome. So you can imagine under syndrome, it's probably heterogeneous etiologies. There may be some different diseases, a final common pathway. It shows very similar signs and symptoms, but we still cannot differentiate what disease caused this syndrome. So, so again, and also another thing that just want to briefly mention is that back in 1993, the POTS is defined as a clinical criteria using tilt table test with a 30 BPM increase and so on. But I mean, just for now, you don't have to forget about this technical definition. Any clinical neurological diseases, we don't rely on just one test to diagnose a disease. So just want to kind of emphasize that. So now going back to clinical features of POTS, I mean, these are really interesting in a lot of young people, predominantly women. We don't know why. There's probably a genetic predisposition there. Young woman, and just about half of POTS patients, they have a sudden onset of this profound fatigue. Now I say fatigue, this is not typical fatigue everybody, normal people can experience. I think I'm pretty busy. I'm tired all the time, but I don't remember when I was tired last week. But these patients, they can remember 10 years ago, exactly one day they developed this fatigue. It's just a profound, debilitating amount of fatigue. And on top of that, they have this weird symptoms of orthostatic intolerance, pain everywhere, and a lot of GI symptoms as well, nausea, vomiting, alternating diarrhea and constipation as well. And it looks like the severe the symptoms also fluctuates over time. Sometimes much worse, sometimes even without any treatment, they seem to do a little better. Now, as you can imagine, during my residency training as a neuromuscular doctor, female doctor, we are learned to, if we see these patients, we are learned to say, these are crazy people. This is not my clinic patient, just go to psychologist. Now, is it really just a bunch of crazy people? Well, through my talk, I've tried to argue that it's probably not. In fact, over time, I actually think if anybody asks me like just one short phrase to describe these people from a physiological standpoint, I would probably say this is paradoxical presence of autonomic dysfunction. Now, what happens? I think, again, as a definition, by definition of POTS, as I suggested, this is probably blood flow control regulation problem. More fancier word is a vasomotor control problem. And now, if you look at the human blood vessels, our blood vessel looks like a water hose, but it's not really steady. It's a very dynamic organ. There's this bunch of smooth muscles here. And there's a little yellow stuff that's called sympathetic nerve fiber that's diving to this wall of the blood vessel. and as it get activated, it squeeze or constricts or dilates blood vessels, so as if it's pumping the blood and increase the blood flow to the target organ, depending on what people are doing. So, for example, if you're exercising, it basically pumps blood, increase blood flow to skeletal muscle. If you're standing up from lower position, pumps blood against the gravity. If you're thinking, increase blood flow to the brain, basically. So basically pumping, vasomotor pump. Now, POTS, again, as a clinical syndrome, whatever the reason is, POTS, probably the fundamental problem is the dysfunction of this vasomotor control. Maybe the nerve here is damaged, or inflamed, or somehow indirectly not working, but it's just not working. And imagine what would happen if that nerve is not working. You won't be able to exercise really effectively, right? And if you, push to the limit, do more than you can handle, you have a lot of post-exercise pain, flare, and sometimes malaise. They get very, very symptomatic after exercise. Also, this fogginess. People have done a lot of kind of work on this fogginess and look at the cerebral blood flow and consistently across POTS or ME/CFS, you see a reduced circulation in the brain. Now, the brain tissue itself is usually normal. There's no specific neurological lesions that they can find, but usually it's a pen-brain problem. So they get not only brain fogginess, lack of concentration, and oftentimes associated with migraine, because a migraine, we know this is some kind of vasomotor problem too. Obviously, there's an orthostatic intolerance, and if you think about it, your heart and lung is in a pretty higher position in the body. So for the blood to travel all the way back to heart and lung, you have to have enough good pump that's traveling across the gravity, which is really not happening, and hence, heart is receiving reduced amount of blood, circulating smaller amount of blood, and causing chronic fatigue and some respiratory problem as well. So I kind of call this pump failure, or vasomotor pump failure. That's explaining a lot of fatigue and fogginess and exercise intolerance. Now, that's not the end of the story there. I think what makes POTS very unique is that there's one more thing that's going on, is that, well, there's a baroreflex, intact baroreflex in these people, meaning basically this is a pressure gauge. I mean, obviously a lot of people here know about this. Basically, this is a pressure gauge in the brain stem that can detect how much blood is coming back to the heart and lung. And obviously in POTS patients, that's a little reduced, and that activates this reflex arc to try to compensate for this pump failure or vasomotor denervation by increasing some chemical neurotransmitters to stimulate the nerve. I told you there's a sympathetic nerve fiber. So basically your brain is trying to increase or stimulate the sympathetic tone to work it harder. And those neurotransmitters are basically adrenaline. Basically, brain is increasing epinephrine or epinephrine to compensate for this so-called pump failure problem or vasomotor dysfunction. And that's inducing tachycardia, which is fast heartbeat. And actually it's a compensation because basically in POTS patients, because of reduced blood circulation, they have a reduced cardiac output, and the fast heartbeat actually compensates for that. So I'm not getting too technical, but cardiac output is function of blood pressure and heart rate. So by increasing heart rate, you can compensate for cardiac output. And that's actually why a lot of POTS patients, they feel dizzy when they stand up for a long time. They usually don't completely pass out or fall down. Occasionally, they actually faint and fall down, but usually they wake up right away because brain is now dumping adrenaline. The problem is this whole increased adrenaline in the body is causing other trouble, making them very anxious and very uncomfortable. And during sleeping, well, adrenaline is supposed to wake people up. It's kind of part of fight or flight reaction. So when you're in danger, they can't sleep. They're supposed to wake up. So it just frequently wakes them up in the middle of the night. And even if they really sleep through the night, they have a very shallow sleep. They have a vivid dreaming, nightmares all the time. They wake up in the middle of the night. Also GI symptoms too. They usually lose appetite because it's part of fight or flight. You're not supposed to, feel hungry and eat something. And it slows down your GI motility, predisposing nausea, vomiting, constipation, although usually alternating with the diarrhea by changing your motility. So in fact, these are equally debilitating problems. So if you ask POTS patient what are the symptoms that bother them, they'll probably list, at least several symptoms, or 7 or 10 or more than 10 symptoms. That includes fatigue, brain fogginess, tachycardia, not being able to sleep, and GI problems. Now, with these numerous symptoms, actually, you can cluster them into pump failure problem, blood vessel, blood circulation problem. I call this pump failure. That includes probably brain fogginess, fatigue, some of the headache, and I call this air hunger, and exercise intolerance. Now, there's another part of symptoms that explains, palpitation, anxiety, not sleeping well, and all the GI problems coming from probably overcompensation. But the physiological standpoint, you're having symptoms coming from, well, again, this is a more oversimplified little theoretical concept, but you have these symptoms coming from sympathetic dysfunction or hypofunction. At the same time, you have symptoms that's coming from hyperfunction or overcompensation of the same system, which is really why treating POTS is so challenging. And even just recognizing POTS is so challenging as well, because first of all, as a clinician, well, there's tons of drugs that I can address this sympathetic overcompensation. Like, for example, I have a lot of drugs that I can use to slow down your heart rate. So I can treat this palpitation or some of the anxiety as well. But those drugs will probably worsen these symptoms on the left-hand side, and vice versa. I have a lot of medication, like so-called ADHD medications, that I can use to perk them up, have less fatigue, but almost invariably will worsen their sleep problem, anxiety problem, and even sometimes GI problem as well. So when you have POTS, when you have this, that's why I say it's paradoxical presence of this autonomic dysfunction. Well, first of all, I think this is actually one of the reasons why I became so fascinated by this condition, because I don't think there's any other disease, not just neurological disease, or just in general. There's a hypofunction and hyperfunction that's causing all the trouble at the same time. Because if you think about it, in disease in general, there's always bad guys. It's like Hollywood movie where there's a bad guy and good guy, and you just get rid of the bad guy, like cancer cells. Cancer cells are bad guys. You get rid of them, everybody's happy. But in POTS, there's really no good guy or bad guy. They're both causing this kind of problem. It's this non-conventional Hollywood movie here. Very challenging. Obviously, there's no one medication that can address all these problems or symptoms. That's why I really personally feel like POTS really requires a really new model of care when you treat these problems. Now, moving on, just a short studies that back up this kind of conceptual framework. So what are the physiological studies there to show what I just told you? Well, like I said, let's just say for the convenience of this talk, separate out vasomotor pump failure problem or sympathetic overcompensations there. Now, traditionally, evaluating studying vasomotor function is really, really challenging. I mean, it sounds a little obvious, but actually it's really difficult to evaluate, how much your body is controlling your blood flow to your brain and muscle and so on. There's no normal values. It's very difficult to study it, but there are a few studies, especially recently, that's been actually showing some evidence backing up vasomotor control problem underlying POTS patients. First of all, transcranial Doppler is basically ultrasound that measures the blood flow in the brain. And if you tilt them up and look at the blood flow changes in the brain, and there's a dramatic reduction of cerebral blood flow that's been shown in POTS and long COVID patients and reproducing this brain fogginess during the tilt. And I'll talk a little more about the invasive form of cardiopulmonary exercises, which has been a little bit breakthrough in the chronic fatigue syndrome and POTS world. And sympathetic overcompensation is relatively easy or easy and difficult at the same time. But you can sometimes a lot of catecholamines are neurotransmitters. It's really difficult to measure in the blood. But sometimes we call this spillover phenomenon, where you can actually see if there's enough exaggerating production of catecholamines. You can actually measure this spillover in the brain in the blood. And people have already shown this spillover on the tilt table test in POTS patients. So you can see this both sympathetic vasomotor dysfunction and at the same time overcompensation as well. Now, I think one of the breakthrough was this invasive form of cardiopulmonary exercise test. Now, this is a little crazy test where if you look at this picture, this patient who's on the exercise bike, and I mean, there's a regular form of cardiopulmonary exercise test where they literally just check their blood pressure, heart rate, and oxygen exchange whenever they are running on the treadmill or bike. Now, this is invasive form where patients are, have this central line put in and the arterial line put in there, and then have them exercise. That's why you see a bunch of surgeons and doctors surrounding this patient getting this test. But this allows people to measure like cardiac, what is called cardiac preload. This is actually the amount of blood that's coming back to the heart and lung from the rest of their body, which is not possible in the conventional methods. And David Sistrom is a pulmonary critical care doctor at Harvard who did this invasive cardiopulmonary test, so-called ICPET, on ME chronic fatigue syndrome patients and POTS patients, and showing that there's a reduction in the cardiac preload. Basically, what happens is, so left, like heart has a left and right ventricles, and this is basically preload, basically feeling pressure that's coming, filling the ventricle, from the rest of the body. And left-hand side is a rest, and the right-hand side is a peak of exercise. And you can see, the black bar is normal, and the gray bar is patient with either chronic fatigue syndrome and POTS. And also he did the same thing, same results in long COVID patients on the gray bar here. And the rest there probably have a equivalent amount of preload. Now, the normal people during the exercise, their cardiac preload goes up, meaning whenever you exercise, you're activating the muscle, so that squeeze and pumps blood back to the heart to increase cardiac output that allows you to do more exercise. Now, as you can see, there's a significant reduction or not much of an exercise increase in the cardiac preload. That's really the basis of not only chronic fatigue, also exercise intolerance as well. And if you push to the limit, let's say if you're really motivated and do too much more than you can handle, like your heart is not really supplying enough of the cardiac output, then you get all this post-exercise malaise or flares with the problem, because there's a mismatch between what heart is providing and what muscle needs. So this is just some quick picture that I made. So normally preload is a whole amount of blood that's coming back from the rest of the body, and then like heart squeeze out of it. It's called cardiac output. And during the exercise, because of skeletal muscles pumping the blood back, you have an increased cardiac output. But in long COVID or POTS or chronic fatigue patients, you just don't get it. You have an even reduced amount of preload that's reducing the cardiac output. That's causing, again, all fatigue and exercise intolerance. Now, these patients are not bleeding, so the blood is not coming back. So where's the blood? So there's been so few studies actually showing that, well, blood is actually being pulled more in the lower side of the body, not coming back to the chest or the brain. So this is a diagram. It's back in 2004 study by Dr. Julian Stewart, who measured blood volume distribution in POTS in normal people. And it's kind of a little small in the picture, but basically, in these POTS patients, blood is being pulled mostly in the lower abdomen and pelvis, a little bit of legs as well. It's not just really gravity. Actually, most blood is being pulled in lower abdomen and pelvis. And some people, still not, we need more studies on that, but some people speculate that why women have more POTS, or if they have POTS, why is it more severe? Because a woman have more organs that's really blood-rich organ in the lower abdomen and pelvis, they can pull the blood extra amount compared to men, which probably explains why women at least might have a more severe spot symptoms. And also that has some implication too. Like if you compression stocking usually doesn't work more to than abdominal binding. So just remember for for treatment standpoint. Now, okay, so let's get into a little what's causing this kind of problem. Like I said, I think predominantly there's a common theme is this autonomic vasomotor dysfunction denervation. Now, is this all neurological problem? Like, say, I'm a nerve and muscle doctor. That's actually why I'm doing POTS. I think this is autonomic nerve problem or neuropathy. But by definition of POTS as a clinical syndrome, anything that can reduce cardiac preload, like on a dynamic or having poor blood control, can cause POTS for sure. And they can include some actual mechanical blockage. Like imagine there's any mechanical blockage down or under the heart chest level that reduces cardiac preload. They can, obviously cause POTS symptoms. Now, hypermobile joint syndrome, some people might have heard about Ehlers-Danlos syndrome. These people have a very loose connective tissue, so they can bend their joints very flexibly. But that means that they have a maybe loose connective tissue, and blood vessels are all connective tissue. And imagine if they have a really loose connective tissue, blood vessels that are really not squeezing and mobilizing their blood, then you may have this blood pooling causing POTS too. There have been some other, it's called renin-angiotensin paradox. People have actually speculated that some hormonal controls or some renin-angiotensin blood volume control problem at the little more hormonal and receptor level could potentially cause POTS too. So what are the evidence there? Actually, there's probably more evidence there in the autonomic denervation there. I'm not going to go too much in detail in technicality, but basically idea is that okay, so basically the idea is that the sympathetic nerve that regulates blood vessels are all their cell bodies is all clustered in what the structure called sympathetic chain ganglia. Now this is not in the central nervous system. It's actually right outside of the spine, and it's right in the thoracolumbar area right there, which I think is really fascinating because this is very extensive. It sends out of the axons to entire body. It innervates to entire blood vessel in the rest of the whole body, but the whole cell body is only clustered with just short segments right there, and outside of the central nervous system. So, maybe this ganglion is under attack, inflamed or damaged or whatever. Or it can be axon, it can be neurovascular junction. We don't know. Maybe it's one of those heterogeneous kind of etiologies there. But regardless, we do have some evidence. Now, QSAR is basically sweat nerve function. Sweat gland is also innervated by sympathetic nerve. And just because, like I said, there's no good direct way of visualizing and evaluating this nerve there, sometimes we use sweat function as a surrogate measure for this sympathetic nerve function because all the sweat nerve comes out of the same sympathetic chain ganglia. And in POTS patients, it's been really well shown that there was pseudomotor dysfunction. There are actually weird sweat pattern too. Just like paradoxical presence. First of all, actually they sweat a lot. Overall, they soak, like overnight they get soaked with the sweat, so-called hyperhidrosis. But if you actually look at this, there's thing called thermoregulatory sweat test, then there's actually patch areas they don't sweat. So overall they sweat a lot because of overcompensation there, but there are some areas they just don't sweat. So these patients, presumably there's some ganglion affected. These segments is just not gonna sweat. And that's another indirect evidence that this vasomotor function is not there. And there's some autonomic function tests called Valsalva maneuver. It shows some potential sympathetic dysfunction there. And microneurography is one of the rare ways to actually evaluate some electric physiology of the sympathetic nerve. It's technically really challenging, and in the United States, it's not reimbursable, so not many people are actually doing it. But there's some evidence coming from muscle sympathetic nerve action, reduced muscle sympathetic nerve activity, underlying participation. So there's quite a lot of evidence behind this sympathetic nerve dysfunction there. Now, like I said, any mechanical blockage can cause this problem too. So think about it. Anything like below this chest level, let's say portal hypertension, liver problem. My colleague, Dr. Furim at Duke, he did this ICP, invasive cardiopulmonary exercise testing on patient with a severe fatty liver disease, somebody who's getting into portal hypertension, cirrhosis. They have a very similar chronic fatigue, POTS-like symptoms, and beautifully showed this preload problem. But there's a lot of different levels in the body that can have some mechanical blockage as well. So mild is called median arcuate ligament syndrome. There's a little weird ligament that can block one of the blood vessels there. Pelvic congestion, there's various different kinds of pelvic congestion problem. The blood is all being pulled in there, especially in the female organs, and May-Turner syndrome at the iliac vessel level. Now, these are, I wouldn't say it's not really super well characterized as underlying POTS etiologies, but people have done anecdotal evidence where, for example, they did some stenting on May-Turner syndrome and open up the blood vessel, and their symptoms got better. Now, in many cases, interestingly, it's not really completely mutually exclusive. I mean, vascular congestion and autonomic nerve dysfunction. In my experience, a lot of people, let's say they do have a MALS or May-Turner syndrome, and with the stenting, it's a surgical, like they can actually open up the blood vessel, and some of their symptoms get better, but not all of them symptoms will get better. So I think there's a lot of overlap between this vascular congestion syndrome and autonomic nerve dysfunction. Not only over the vascular congestion problems, there's a lot of actually syndromes that are overlapping with the POTS as well. I already told you chronic fatigue syndrome. These days we call this myalgic encephalitis / chronic fatigue syndrome, so-called MECFS. These are like very overlapping with each other, so I didn't include there. But some people, they say it's called mast activation syndrome, hypermobile joint, another name for this is Ehlers-Danlos syndrome type 3. There's a lot of GI problems, small intestine bacterial overgrowth syndrome, so-called SIBO, or irritable bowel syndrome, and some numerous other syndromes there too. Well, let's just get really brief on some other prominent syndromes. Now, it's called MCAS, mast activation syndrome. This is not a true allergic reaction, but interesting, a lot of POTS patients, they get very sensitive to foods or drugs that they didn't have any problem with before. So it's not a true allergic reaction, but usually they're very sensitive to drug and weird foods. So it's not an allergy. And basically the theory, now, I'm not an immunologist, and full disclosure, like if I talk to, let's say I have 10 immunology colleagues, 5 of them will probably say, oh, this is not a diagnosis, nobody really believes it. My other 5 will probably say, this really exists, nobody knows what's causing it. I think the name basically suggests that is that mast cells are the cells that produce chemicals that mediate inflammation reaction. And their theory is that instead of traditional classic allergic pathway where the antigen antibody binds and stimulate the mast cell, these mast cells are maybe unstable and they just open up and causing these allergic reactions. And this is coming from my colleague in Vanderbilt, Dr. Cynthia Shabal research review paper, and which I tend to agree that also mast cells can be activated by enough catecholamines. And like I said, there's a lot of epinephrine, norepinephrine released in the body that's probably activating these mast cells and having a lot of this kind of allergic syndrome. It's really interesting enough. It's not, if you really see those patients, they do actually have actual rash, like swelling rash and actual inflammatory reaction. This is not just people can imagine it. So there's some interaction between this inflammation and POTS in MCAS patients. And majority of my POTS patients, interestingly, not everybody, but Ehlers-Danlos, having Ehlers-Danlos syndrome, they have a very flexible joints. Not everybody has that, but a lot of people do. So maybe there's some genetic predisposition there. Now they labeled it as an EDS type 3, But basically, to diagnose EDS type 3, they do gene testing and have to rule out other known hypermobile joints. So basically, it's almost by default, if you're clinically flexible and no gene known to be associated with this hypermobile joints, then you call this EDS. So it sounds like genetic diagnosis, but whether this is actually genetic condition or something else, we don't know. I do have several patients who claim that they became very flexible after having developing POTS. So could it be just acquired? It's really possible at this point. And again, like there's certain criteria you can diagnose EDS with. This is very arbitrary. There's some, as you can see in the pictures, there are certain points where how flexible you are. You can touch the thumb to the forearm, so on. Very arbitrary. To be honest, I actually asked the person, one of the people who came up with this diagnostic criteria, how did you get with this whole thumb to the forearm and the pulling the finger? Did you have any normal population research? And no, never done it. It's just in my experience, these people are really flexible. So I think they're really interesting. There's more research to be done, but at this point, it's really diagnosed, clinically. Now, just summarizing this part, like you see, not only POTS, and like as a clinician, you see POTS patient. If you look at the medical record, I mean, most of these people were seen by like 10 other doctors before, and they get several other diagnoses, whether MCAS, Ehlers-Danlos syndrome, IBS, progressive tachycardia, you name it, fibromyalgia, you have everything. Is this all real, like different thing? I mean, so people, like I said, a lot of people actually develop these symptoms abruptly. These people are usually very healthy, active people prior to onset of these symptoms. So how come people suddenly develop like 10 rare diseases at the same time? It doesn't make sense. I think this is probably one thing. So I don't know if you heard about this blind man, 6 blind men and elephant. So I think it's the Indian folk or British folklore where basically there's one elephant in the room and 6 blind men touching different part of elephant and thinking, oh, it's fair, it's a fan, it's a wall, but it's the same thing, right? So I think POTS currently, I think this is just, we are in the blind man situation. I'm one of the blind men, okay? Maybe if a neuromuscular doctor, cardiologist, oh, you call this POTS. Your allergist, oh, you say this is MCAS. Your geneticist, you're saying this is EDS. If you're a pediatrician, well, I actually forgot that. If you're a neurologist, oh, this is crazy. It's nothing, right? So we label people and the same people, the different things. And actually, that's how, when I first started POTS clinic, that's how it became a little bit of multidisciplinary clinic, because I didn't realize that my patients are seen by GI doctors and cardiologists and rheumatologists. So I reached out to them and just found that these are the same person, the different diagnosis on the same symptoms. So I think people are now starting to slowly recognize, okay, well, this is just one elephant there. So we have to work together, which is really probably one of the most difficult part. Like I think you guys are doing a great job in collaboration. That's what I heard, but tradition is not that easy, right? I'm going to very briefly talk on the treatment strategies. So basically, I'm addressing 2 different paradoxical, but cautiously approaching sympathetic hyperfunction. We do volume expansion. We try to increase blood volume. And if they have a symptoms that are really sympathetic overcompensation, then I try to address that. The volume expansion, we try to do what is called oral rehydration solution. This is developed by WHO and UN. Basically, their goal is to really, like in third world countries or low income countries, there are a lot of kids dying out of diarrhea. So WHO, they developed this simplest possible way to increase blood volume and keep the hydration going on to prevent from dehydration. You can actually Google it. You can actually, there's a lot of free recipe there. So, a lot of drinking water with a lot of high salt in it to increase blood volume there. And also, there are a lot of medications that can help, vasoconstrictors or fluid retention drugs, and eventually physical exercise is one of the actually interesting, first of all, it's a very powerful intervention, but it's not an easy thing to do. Now, like I briefly mentioned, when you do exercise, your skeletal muscle pumps the blood and increase return of the blood to the heart and lung. So immediately during acute exercise, there's almost like 2, 3, 4-fold times increase in the blood volume circulation during the exercise. Now, over long term, it's an adaptation to chronic cardiovascular training. where human body makes more red blood cells because now like realize that, oh, I need more oxygen delivered. So they make more red blood cells, and it takes up volume in the blood. So it can increase blood volume. And sports medicine, there's a lot of research articles about it. A lot of people, know people, when they over chronic cardiovascular training, they can increase blood volume up to 30 to 35%. So imagine you can increase blood volume through exercise. It can help with their core problem there. But the problem, like I said, is when you do exercise more than you can handle, you're gonna pay the price. If a severe acute exercise flare, sometimes so dramatic enough that I've seen patients who got set back for years. Like they have so severe flares after exercise that it's just years, and most oftentimes days and weeks they have to be in the bed. So just almost going back there. So it's really challenging problem. Again, this is one of the things that the conventional physical therapy, I'm a PMA doctor, like I said, and where I can just prescribing exercise, it's just not gonna work. It's very interactive, and also medical care and physical intervention has to work very closely in conjunction. If they have a flare, we sometimes do very aggressive volume expansion, sometimes the IVCN infusion to get through these exercise flares. So it's challenging. And also, unfortunately, at this current, insurance or medical like insurance system, nothing really works well. Like it's very struggling to do this. But again, concept is very graded cardiovascular training, very at the very low level. They slowly amp up their cardiovascular training intensity over time with the goal of increasing blood volume. Now, and also there's some medications I use to knock down the adrenaline tone, beta blockers, and sometimes anti-anxiety medications, such as benzodiazepines and so on, which is not my favorite medication because oftentimes their primary debilitating symptoms are fatigue, and a lot of these drugs make them very tired. So we always have to struggle with side effects and effects, and they are very thin line. So I prefer some more non-pharmacological way of doing this sympathetic symptoms such as meditation, mindfulness, so that they can calm down, regulating their overcompensation as well. Now, saying that, none of these treatments that I told you are really curing any of this. It's not a cure at this point, right? And not really even addressing fundamental physiology or etiology there. Like we are just, it's a symptomatic treatment in a way, right? There's volume expansion and treating some sympathetic symptoms. Are there any way to intervene at the more fundamental etiological level? Possibly, yes. I mean, the primary thing that I'm looking at is immune therapy. Like I said, just about half, a little more than half of patients develop these symptoms acutely after some kind of infection that's suggesting autoimmunity there. So basically what happens maybe is that SARS-CoV virus or any virus coming in, the virus is gone, but maybe their molecular structure looks very similar to their own body tissue, maybe in this case, sympathetic nerve here. So they develop maybe autoantibody, whatever immune system recognize these structure as virus, so it inflames itself and causing these spots. So like I said, so at the fundamental level, it'd be great if you can just prevent COVID infection. So hand washing, hygiene is obvious, right? I think it's really still important treatment. Like I said, volume expansion, some other treatments that I just mentioned. But how about if you can manipulate the immune system, calm down, stop the inflammation? Still not the cure, but it's addressing at the fundamental level. And another great thing is that if you can identify this autoimmune subset of POTS patient, there's a lot of drugs out there that's already used for other diseases. We can just use it. So there's a lot of research going on to try to first identify the subset of immune mediated POTS patient. Because if you do, I think this is like, you may not address all POTS patients, but these patients dramatically can get better. And it's based on a lot of people's anecdotal evidence, experience, including myself. I use IVIG or other immune drugs. They get actually a lot better, a lot more than, nothing can be explained by just drinking a lot of water and other medication. So there's still signal there, a lot of research going on, and it'll move faster. So going forward to research, as I suggested, first of all, my primary interest at this point is really by identifying this autoimmune subset, but there's a research needed in every aspect of POTS at this point, because unfortunately, this is disease that had been really ignored by medical community for such a long time. I mean, it's 1993, it's relatively new, but there's a lot of political reasons, whatever. I'm not going to go over that, but it just had been very ignored for many decades. I think COVID pandemic has been bad news for humanity, but good news for existing population. Now people are finally paying attention to this problem, and yeah, this is real. I actually have my own, like old school neurology doctors at Hopkins. Like when I first started POTS clinic, which is before COVID, they're saying like, oh, you can't do this POTS clinic at Johns Hopkins. This is Johns Hopkins. You can't do this. It's like a bunch of fake people. And the same doctor actually referred his own, family. I'm not happy with that, but I'm just in a way relieved that now he's actually seeing this as a real problem. He's actually referring because now he's seeing his own family and friends, suffering from this POTS symptoms. So, yeah, like I said, I think biomarkers is one of the really core, cornerstones research. We don't have any serum biomarkers at this point. We did a little bit of this proteomics approach. We are collecting all the blood, partnering with the proteomics lab. We did so post-COVID POTS, which I think is a more homogeneous subset of POTS patients and healthy controls. And we actually see just about 30-something proteins separating clearly. If you can see this panel D there, clearly separating from control and POTS patient, which I think we're really excited about this. And we are planning on validating this with some other proteomics technology to further validate this biomarkers. And there's been similar studies actually there, like late last year and early this year. Actually, both studies are coming from Swedish group, Artur Fedorowski. They did a little different proteomics method, so-called O-link, and they found what's interesting about this is that it's not exactly the same protein. There are a few that's overlapping. Most of them are a little different, but a lot of them are coming from pro-coagulation pathway and inflammatory pathway there. So there's a very common similarities there. And another interesting that the Swedish group did was that they actually collected all the long COVID patients. Some of them were diagnosed with POTS, and some of them are not diagnosed with POTS. And try to see if there's any difference, just like the elephant, because they're coming with a very similar symptoms. And you see the panel C, if you compare post-COVID POTS versus post-COVID without POTS, you don't see any difference in proteomics profile, which I think is really kind of fascinating because the proteomics, you usually see this large, they're testing thousands of proteins, and usually you see like, hundreds, if not like tens of these protein differences there, and you don't see any difference between post-COVID with or without POTS. So that's probably suggesting that large part, even though they're not diagnosed with the POTS with the current diagnostic criteria, maybe it's the same elephant. That's probably one of the fascinating things. More recently, it's actually not published yet. Preprints and the Yale group actually did what is called passive transfer experiment, where they collected blood from patients, extract immunoglobulin, which we think is probably one of the autoantibodies, IgG-based immunoglobulin, inject to the mice, and they reproduce some of the symptoms. They have a hard time mobility-wise and heat latency or pain perception there too. So that's one of the gold standard of proving autoimmunity in a autoimmune neurological diseases. All right, so and also, like I said, pandemic has been a little bit of opportunity. I was lucky enough to get connected with youth from Argenex is a big company who manufactures this drug called efgartigimod that lowers IgG level. And we just recently actually finished the study last week because preliminary phase 2 results didn't show statistical difference. However, I think still this is the first sponsored trial in the history of POTS. I think we are really excited about that. And the preliminary results really not discouraging in moving forward with other trials. So we are really excited about that. There's an NIH has just launched a very big trial. As part of that recovery initiative, the autonomic is termed as NIH autonomic trial, although patient eligibility is a POTS trial. But like again, this is political. A lot of people at the NIH level, they don't want to say POTS, so we call this autonomic. But they just started recruiting IVIG. Also, it's an autoimmune subset. We're intervening with the IVIG. There's one more trial, and didn't bring the slide. There's a subcutaneous immunoglobulin trials. I feel like after COVID pandemic, I'm hearing from some pharmaceutical companies that are interested in POTS. There's so many patients out there. I think they are studying to say, oh, there's many money in there. I'm not gonna blame them. It's a great opportunity for us. I mean, this kind of money industry interest will eventually, hopefully, resulting in some meaningful results there. So like, a brief introduction, we started 2017, we grown pretty quickly. Like we have, these are our faculty level. Britt is a rheumatologist. We're doing a lot of research, particularly interested in autoimmune phenomenon. Suzanne is actually ophthalmology. And interestingly, she found this called this confocal optometry, where you can see the small ophthalmic fibers. And she saw a lot of inflammation and small fiber destruction in the eye, ophthalmic nerve, which became pretty interesting. So she joined two full-time nurse practitioners seeing all the POTS patients. And these are four, we have several therapists, but these four therapists really kind of came up with this whole program together. So we like to call ourselves POTS Avengers. All right, so just we have, I think, 10 minutes. Yeah, this is why doctors are running away from POTS if they hear POTS, because it's so challenging. All right, questions? I have 10 minutes. Thank you very much.
Okay, we have some questions from online. People want to know, what is the life expectancy of patients diagnosed with POTS and at what age do they typically develop?
What age, what?
What age do they typically develop it?
Developing, okay.
And their life expectancy?
Yeah, so I think there's no really good long-term studies. So it's just coming out of more surveys, not real, like really true research, but life expectancy seems to be not much effective. I mean, it seems like looks like they're actually living just about the similar life expectancy in their demographics. Although, again, POTS is a heterogeneous syndrome, so maybe there's some subpart may have a little different results there. Typical onset age, you look at the textbook, will probably say late teens to early 20s, but also it depends on probably etiology there too. I think majority of POTS patients that I still see are the ones who develop POTS symptoms late teens after Epstein-Barr virus, which is mononucleosis, which most people have it at some point in their life, which is usually late teens, and maybe likely as autoimmune phenomenon they have it. I think post-COVID POTS, long COVID POTS patient seems to have a little later onset age, all the way from 20s to 40s or 50s. So those are, but usually young group under 40s or 50s.
Does POTS go into remission?
So, I mean, in a lot, I think remission is a very interesting word. I don't think there's a true remission in a sense that, like, for example, some multiple sclerosis patient under remission, they actually are completely symptom-free. They may do a little better, but they still have a lot of symptoms. So the waxes and wanes, I try not to use the term remission because nobody can really clearly define what remission is in POTS. So, but they can do a little better in between the flares. Yep.
Hi there. Thank you for your talk. Cerebral blood flow is very well auto-regulated through local mechanisms. So what do you think is happening in these patients with myogenic and metabolic control of blood flow?
So I think there may be some subset of there too. So I didn't really show the whole graph there. There are many. It's not many people that are transcranial Doppler studies and on the tilt table test. And Dr. Novak in Harvard, he did. So if you adjust because when they do tilt, especially when you have a POTS, they hyperventilate and there's a little lower CO2 level. If you adjust for the CO2 level, they still have a reduction in cerebral blood flow and suggesting some vasomotor nerve control problem rather than other myogenic control problem.
Yeah, so I was sort of thinking that something's overriding those responses. And when you go into the autoimmune hypothesis, David Kem described a number of autoantibodies,
Correct,
different ones in different patients, that sort of overrode the vascular response.
Yeah.
Has plasmapheresis been tried?
Not in a clinical trial yet. It's still very anecdotal in the plasmapheresis. Yeah. And David Kemp's antibody GPCR, it's actually really fantastic. Commercially, there's two companies based in Germany that are testing GPCR antibodies, but it's really not reliable. We've actually tested on non-COVID POTS patient. There's so many non-specificity there, so it's really not reliable. But the GPC antibodies are really adrenergic receptor antibodies and functionally interfering with this vasomotor control. But thank you so much for bringing that.
Thank you.
Yeah.
Can you go back onto your slides? You had a treatment algorithm. Go
which one?
back. Yeah, I know. More. Go back about yeah, the next one.
Yeah,
The next one.
back before, right?
The treatment.
You mean the treatment?
Yeah, you. Oh, yeah, that's okay. Just the one before this. Okay,
Oh.
that right there.
Yeah.
So right there, you say drink 4 liters of water. Now, I have tried this before in my patient population. The only problem that once you start doing that, they get edema, but I never saw the POTS go away. Can you comment on that, please?
Yeah, I mean, so yeah, some people get some edemas, and it's eventually well studied, especially in the pediatric population. They get some puffiness when they didn't drink this amount of high salt water. To be honest, I don't have I mean, some people, especially young women, they don't want to look puffy, and that can be quite a bit of concern as well. But my general experience, so I call this more risk of drinking water treatment. Not only that, they go to bathroom all the time. That can be quite annoying as well. But the potential benefit that's getting out of this water drinking is really, in my experience, in many cases, outweighs this puffiness, little edema, and frequent trip to bathroom too. Another thing that everybody, I mean, as a clinician has to keep in mind is that they may not feel like completely energetic and better after drinking like 4 gallons of water, but it's a basis for other treatment too. So if I do midodrine or vasoconstrictor or fludrocortisone, they're not drinking this amount of water, I know it's not going to work. So it allows other treatments to work, which I think is also a benefit of drinking water. Yeah, again, there's really not much, I can address about that puffiness, edema. Sometimes they have a GI problems, the yucky, that too. Midodrine works pretty well. Yeah, midodrine really works well. I like midodrine because it's a relatively short acting. So if they have any side effects, I can stop and just get out of the body quite quickly. Generally, I love a short acting drug in heart patients because I can go back and forth pretty quickly, depending on how their symptoms change. Fludrocortisone is pretty good too.
So Dr. Chung, I really appreciate you sharing your research and for your excellent work for our patients. I did want to ask you if you deliberately excluded physiatrists from your elephant illustration. It seems like you did. That was so physiatrists aren't blind, I guess. So I like that as a physiatrist, as a physiatrist. But as a token of appreciation, I really wanted to, we want to share this for
Oh,
your
thank you.
work.
Thank you very much.
So this represents our goal to improve health here in Missouri and beyond, and what you're doing is really impacting patients. So thank you so much.
Thank you very much. Thank you. Thank you.
And we have a very exciting speaker next month. Maybe not quite as exciting as Dr. Chung, just kidding. Very exciting, Dr. Tracy Shore. So please join us. Thank you.